Our second speaker is Dr. Divyendra Datta, who is going to talk us about the postpartum sepsis. Dr. Datta is experienced consultant in obstetric and gynecology, and with a great interest in high-risk obstetrics, pelvic floor surgery, clinical research, and medical education. And now we have a specialist in medical education, and I'm sure that this presentation is also going to be very useful. Like the first one, very important for the clinical practice. Dr. Datta works in UK, in Kent County, in Royal Tunbridge Wells Hospital, and he was a member of Council of Royal College of Obstetrics and Gynecology and its member of Board of Trustees. He also pioneered in simulation training in Kent and enhanced recovery in gynecology in Academic for Health Sciences. He is skilled healthcare management, clinical research, medical education, medicine, and patient safety. He is also honorary senior lecturer in King's College in London, and recommended by our dear colleague and friend Milica Perovic, who also is co-worker with Dr. Datta. We got and accepted the invitation. Dr. Datta accepted the invitation to prepare this lecture. So, Dr. Datta, thank you once again for being here, and I give you the floor.
Thank you. Can you see my first slide?
We can see the slides and we can hear you well.
You can hear me, right? Okay, so I'm going to talk about postpartum sepsis, and there's been a lot of consensus about how we diagnose, treat, and there are lots of guidelines which have been published by the World Health Organization, the American College of Obstetricians and Gynecologists, the Royal College, and other societies. Okay, so what we're going to learn is define or understand puerperal sepsis. We're going to try and understand the risk factors for maternal sepsis, explain ways to prevent sepsis, causes, symptoms, signs, and management of the condition, and list the indications for antibiotics and the recommendation of broad spectrum antibiotics. Okay, so in maternal sepsis, what you're thinking about is it's a life-threatening condition which results from infection, of course, but what the infection does is it creates a dysfunction in the organs. So it can lead to liver failure, it can lead to kidney failure, it can lead to heart failure, and also cerebral failure. So that's the problem and the risk. So all of this can happen during pregnancy, during labor, at the end of pregnancy, following abortion. So anytime a woman is vulnerable to sepsis. So anybody who's pregnant, who's had a miscarriage, or an abortion, induced abortion, can develop maternal sepsis. So what are the signs? So the woman will come to you with fever, feeling hot, uncomfortable, maybe tender uterus, dryness of the vagina, offensive vaginal discharge. But what you are going to elicit in the way of signs, a fever or hypothermia. So not always raised temperature, but sometimes in later part of the process, you can have a shutdown of peripheral circulation, and you can have hypothermia or cold extremities, plus any of the following. You can have a fast heartbeat, so tachycardia, you can have hypotension, low blood pressure, you can have respiratory distress, tachypnea, so any respiratory rate, something over like 18 or 20 respiratory efforts per minute. You can have jaundice on account of liver failure, decreased urination, again that's pointed to renal failure, and altered mental status if cerebral perfusion is compromised. So any of these signs, then you have to think about sepsis. I would say, anybody who's pregnant and shows any of these signs, especially fever or hypothermia, with any of these four conditions, you should think maternal sepsis. So what is the difference between maternal infection and maternal sepsis? I think sepsis is a word that is used to denote multi-organ involvement. Okay, infection, you talk about respiratory tract infection or urinary tract infection, but when you're talking about sepsis, you're talking about multi-organ involvement. So you're talking about an implied septicemia, where the bacteria or the offending organism has spread through the body, through the bloodstream, and I think that is more dangerous than localized infection. Okay, so it's a leading cause of maternal death in the postpartum period. The major killers are obviously, as you heard from your previous speaker, hemorrhage, you have abortion, obstructed labor, preeclampsia is not mentioned here. In others, you've got preeclampsia, thromboembolism also kills, and cardiac problems, and besides psychiatric problems or psychological problems like suicide, mental illnesses can also cause death, apart from hypertensive disorders. In the developed world, in Europe and in North America, we're talking about the sepsis causing deaths in about 10 to 15% of the population, but in less developed parts of the world, you can have them as high as maybe 20 or 25% causing death. So maintaining hand hygiene, hand washing, that's obviously something that is very apparent. Reducing frequent vaginal examinations in labor, and early identification and judicious use of antibiotics in mothers showing infection, so that the process does not snowball into sepsis. Okay, so how does the pathophysiology work? So when sepsis occurs, which I told you was spread of infection through the bloodstream, you have endothelial injury or injury to the lining of the blood vessels, and these could be in the lining of the blood vessels of major organs like the heart, and the liver, and the kidney, and the brain. And then what happens is the initial rush of the macrophages, so inflammation, you have got a high white cell count, including neutrophils. You've got coagulation disorders where you've got the clotting factors being rapidly consumed, like fibrinogen and the whole clotting pathway. You have fibrinolysis, so blood clotting is not retained. So you can have breakdown of blood clots leading to fibrinolysis, and that leads to disseminated intravascular coagulation, where means the body is unable to retain its ability to clot, and so hemorrhage can occur. So sepsis can lead to hemorrhage, and obviously the surgical measures of hemorrhage will no longer work unless you replace what the woman has lost. For example, packed cells, you have to replace fibrinogen, you have to replace fresh frozen plasma. So until you correct disseminated intravascular coagulation, unless you correct sepsis, the infection, you will not be on top of hemorrhage. So one thing leads to another, and I think that is what this implies. Eventually, if you let things slide, if you are late in correction or you haven't picked up, then you end up with organ failure. You could have acute renal injury and renal shutdown. You can have respiratory distress syndrome, hypotension, shock, and finally death. So I think the pathological pathway is fairly common to understand, but what we have to do when you diagnose sepsis is limit the endothelial injury to different organs, and thereby limit the damage that this endothelial injury will cause to various organs. So puerperal infections is a general term. It includes puerperal sepsis or sepsis in the puerperial period, that's the postpartum period, and you have infections of the genitourinary system. So what that means is the uterus, the fallopian tubes, the ovaries. You can have pyosalpinx, you can have endosalpingitis, you can have salpingo-oophorytis, you can have urinary tract infections, you can even have kidney infections, and infections especially related to birth process, which means what? Which means for the infection of soft tissues in the pelvis, like you can have a perianal abscess, you can have a vaginal abscess, you can have a broad ligament hematoma and abscess. So all of these can be defined under the umbrella of puerperal infections. What is not included are things like breast abscess and other infections like malaria in different parts of the world, or Kala-Azar, maybe in the tropical areas. You can have respiratory tract infections. These are not puerperal infections as such, although they happen in the puerperal period, but they do not count as a puerperal sepsis or puerperal infection. How do you diagnose it? So obviously the definition I've given you there, it's an infection of the genital tract, that is of the upper and the lower genital tract, anytime between the onset of rupture of membranes or labor and the 42nd day. So we say 6 weeks is critical. You will find the 6 weeks is the cutoff mark for thromboprophylaxis, for example. 6 weeks is the cutoff for hypertensive disorder. So a lot of the time, maternal death statistics also include up to 42nd day. So puerperal sepsis also follows that rule, and which any of the 2 or more signs are present. So you've got a fever, which is more than 38 degrees centigrade or 100.5 degree Fahrenheit, abnormal vaginal discharge, foul odor, like I told you about, a vaginal discharge, lower abdominal pain, subinvolution of a tender uterus, and general feeling of unwell. But these are the ones that you see, like we said, hypothermia sometimes, but high fever, vaginal discharge, or local signs like lower abdominal pain and subinvolution. So systemic examination, what you should check for, obviously you start examining the uterus, the wound, and abdomen for collection. Any suspicion of ovarian vein thrombosis or torsion of that adnexa, you would actually rule out by ultrasound. You then examine the perineal wound. If she has had an episiotomy or an extension of a tear, you look at the wound just to make sure there is no paravaginal collection like a hematoma or an abscess. Then you move up and check the breasts. In case there's a breast abscess, check for respiratory tract infections. Temperature, vital signs, of course, urinary output, of course, check for meningitis, signs of altered mental status. So if a woman after delivery or during pregnancy is confused and actually is abusive to you, don't think she is being hostile. Maybe it is because her cerebral perfusion is reduced and she cannot think straight, and that may be on account of either a blood clot or sepsis or hypertension. Look for lower limb thrombosis. So that's something else you need to look at. So it's a general examination, but you start in the area as gynecologists and obstetricians. You start on the abdomen, the uterus, the vulva, the vagina, and the urethra and surrounding areas, and move on to systemic tests. Okay. So these are the variables. It's a busy slide, but I'm going to take you through very quickly. So generally, you're looking at fever or hypothermia, so less than 36 degrees centigrade. Like I said, heart rate and respiratory rate. So tachypnea or fast breathing is somewhere over 16 to 18 per minute. And that will tell you heart rate over 90 beats per minute. Altered mental status, like I was telling you, confused, aggression, can tell you significant edema, positive fluid balance, hyperglycemia in the absence of diabetes. So these are the general signs. So when you're looking for temperature, the heart rate, respiratory rate, the mental status, edema, a bedside test for plasma glucose. So those are the general ones that you're looking at. What are the inflammatory variables? So your blood count, your white cell count will go up more than 12,000. Your white cell count can go down in very severe sepsis, less than 4,000. You can have a normal white cell count, but with more immature forms, which means the bone marrow is trying to produce more and more white cells, but they are not quite in the mature form. The C-reactive protein will be over 2 standard deviations above normal value, and the procalcitonin, which is another inflammatory marker, again, 2 standard deviations above the normal value. So what about hemodynamic variables? So you have arterial hypotension, so systolic less than 90, or an SBP, systolic blood pressure decrease of more than 40 in adults, less than 2 standard deviations below normal for age. Oxygen saturation should be over 70, but decreased saturation should alert you to a possible hypoxic state. And cardiac index, again, anything more than 3 or 3.5 liters per minute per meter squared is what we take into account the BMI in that. What about organic function variables? So you had hypoxemia, and here you might need the help of your anesthetic colleagues and friends, to read blood gases if you like. You want to check what's the partial pressure of oxygen and also partial pressure of carbon dioxide, including oliguria, so urine output reduces. Generally, I teach my students it's less than 80 mils over 4 hours. I think that is the critical time. Any 4-hour window, if the woman is putting out less than 80 mils, then I think you should be worried. Creatinine, again, increase in creatinine over previous values. So if you're looking at creatinine and it has increased over pre-pregnancy or pregnancy levels, you think of that. Coagulation abnormalities, with an INR of more than 1.5, PTT or prothrombin time more than 60 seconds. And then if you auscultate the abdomen, you might find absent bowel sounds in sepsis. Sepsis also leads to atony. One of the factors that contribute to atony is chorioamnionitis or sepsis. So you should be aware that atony might have its etiology apart from tissue thrombin and tone and trauma. So thrombocytopenia or platelet count lower than 100,000, or hyperbilirubinemia, which is actually telling you that the liver is trying to fail, and plasma total bilirubin, depending on what measure you use, the more than 4 milligram per deciliter or 70 millimole per liter. And decreased capillary refill or mottling of the skin. You might find mottling of the skin, not very commonly. Again, in darker races, you might not feel or see mottling. So you have to take into account all of these. So look at general variables, look at the inflammatory variables, like the blood test results, look at the bedside blood pressure, oxygen saturation, and then you look at the blood gas, the urine output, creatinine, coagulation, bowel sounds, platelets, and liver function test. So all of that is going to help you understand, but once you get the clinical signs in your head, then it's very easy to put these together. So what are the risk factors? Pre-existing sexually transmitted infections, or non-immunized against tetanus, previous existing diabetes. Diabetes does not help sepsis because it does not allow the infection to heal despite antibiotics. And again, sepsis worsens diabetes. So it's like a non-ending circle. So tight control of diabetes is important to combat sepsis and infection. Poor hygiene, large body habitus, for example, high BMI, maybe pre-existing anemia, and malnutrition, especially in developing countries, will make the woman more likely to enter into sepsis and infection. So failure to follow infection prevention practices, poor monitoring of the mother in labor. I've lost my screen. Where is that? Where did my screen go?
Sorry, Dr. Datta, what do you need?
My screen. I've lost my screen. Where is it gone?
So maybe try to reopen the presentation.
Yeah. Yeah, there we go. Yeah. So you can see again. Can you see?
Yes, everything works.
Right. Okay. So poor monitoring of the mother during and after labor, frequent vaginal examinations, prolonged or obstructed labor for more than 24 hours, cesarean section, instrumental delivery, manipulations high in the birth canal, for example, internal portalic version, and also things like unrepaired vaginal or cervical injuries and lacerations, and postpartum hemorrhage again merges into sepsis. Okay, so what do you want to do in terms of measures to be taken? To most extent, it is preventable. Much depends on when the woman is presenting. For example, if you are working in developing countries where the patient is taking a long time to come to the health center, then obviously a lot of things are happening already, and you might be restricted or prevented from taking early measures. So before and during delivery, you provide an emotional support. Partogram will avoid prolonged labor, limit vaginal examination, especially in preterm pre-labor rupture membranes, especially in pre-labor rupture membranes before term also. You limit vaginal examination, diagnosis and treatment of pre-existing sexually transmitted infections like chlamydia and gonorrhea, asepsis during delivery as far as possible, and trained personnel who have knowledge of hand hygiene. After delivery, maintain perineal hygiene, maintain hand hygiene, clean sanitary pads, diagnosis and treatment of urinary tract infection, anemia, malnutrition, especially in the developed world, and also diabetes. So make sure there's a tight control of diabetes. Okay, so principles of management are, looking at vital signs. If patient is non-toxic, check fever, pulse not rapid, start oral fluids, use routine microscopic examinations, antibiotics. Sometimes we might need to start intravenous antibiotics depending on the stage of infection and sepsis. rule out the presence of retained bits of placenta because they can be a focus of infection, especially after prolonged labor, especially if the placenta is not complete. Monitor vital signs, watch for 24 hours, and then complete the course of antibiotics for 5 days. If vital signs are not improving, discuss with your anesthetist, discuss with another colleague, and think about intensivist and referral to ITU. Obviously, if there's high-grade fever, and I'm talking about the right-hand side of the slide, a rapid pulse, you got to start intravenous antibiotics and rule out a retained placenta. Consider intensive care unit where they can monitor very closely the fluid input, output, and also the vital signs, and also keep measuring the CVP. Sometimes they might need to monitor central venous pressure to ensure that they are registering the correct reflection of the arterial pressures. Recommended antibiotics, this will differ from country to country. I've just written what we use in Great Britain and Ireland. Maybe it's different where you work, maybe it's different in Western Europe and in North America, but broadly you start with a penicillin. It's either ampicillin or amoxicillin. You can use piperacillin and use metronidazole as well for the gram-negative organisms. Gentamicin, 5 milligrams per kilo per day. You can use IM. Sometimes the anesthetist will tell you the intravenous dose. And the broadest coverage is where you've got a broad spectrum penicillin with gentamicin and metronidazole. You could do culture studies like, low vaginal swab culture. You could do a culture of the midstream specimen of urine, or if you've got a placental surface swab, you can actually check for infection. If there's sputum, then you can culture the sputum as well and try and find out if there are other penicillin resisting antibiotics that we might need to use. Always speak to your microbiologist and they'll be able to help you in terms of trying to choose which one antibiotic might be suitable in a particular scenario. Okay, so it's one of the leading causes of maternal deaths. It is to a large extent preventable, but much depends on when she presents to you. Antibiotics should be given if they're indicated, and antenatal midwives should be able to identify the indications for antibiotics before the first dose, before referral. So that's all I wanted to say. I think I'll conclude my presentation. I hope I've not exceeded my time.
Everything was just perfect. Dr. Datta, thank you very much.